Welcome everyone to our Thursday afternoon webinar series. I am going to just wait a few minutes for everyone to get connected to their audio. My name is Lourdes. I am a Director of Patient Services with the Cholangiocarcinoma Foundation, and we are always glad that you join us for our webinars. Just a few announcements before I introduce our speaker for today. If you have an FGFR mutation, you can find FGFR kits on our website. So check that out. If you do have one, those kits are free. And campaign for the cure is wrapping up this month. So to learn more and donate, please go to our website. I am happy to introduce Dr. Bose. He is the Director of Surgical Oncology at Mercy Medical Center in Baltimore, Maryland. He focuses on hepatobiliary and pancreatic surgery. Dr. Bose is a Baltimore native where he attended University of Maryland School of Medicine and trained at the Johns Hopkins Hospital for residency. He completed his training with a fellowship at the University of Texas MD Anderson Cancer Center. Dr. Bose was the Chief of GI Surgical Oncology at the University of Florida Orlando Health Cancer Center prior to returning to Baltimore. Thank you, Dr. Bose, for being here with us. And just before I hand it over to you, as a reminder to everyone watching, please put your questions on this topic into the Q&A or the chat, and we will get to those at the end of the presentation. Thank you, Dr. Bose, for being here.
Thank you for having me. It's my pleasure. As I was thinking about what kinds of things I might be able to share with your group that might be helpful, one of the things that occurred to me was that probably your group is very well informed about treatment options, types of treatments that we do, and those kinds of things. And I think to sort of rehash those things would have been kind of redundant probably for your group. But one thing I don't think we talk about enough is, well, how do we as providers talk to our patients about their treatment options? How do we help them make decisions as to what treatments to pursue, what kinds of things will help them achieve their goals in terms of once they've got such a diagnosis, what's the best way to approach the conversation? And so I wanted to talk a little bit about that today. I'm not going to show a lot of clinical pictures or anything like that. I have just a few slides, but I'm going to be talking a lot about some stories about patients and how we came to decisions together, sometimes in ways that maybe we could have done better, but I think they illustrate some of the issues around these conversations. So first of all, I wanted to let you know that I have no disclosures. I'm part of a team of surgical oncologists here at Mercy, going from left to right. You see Dr. Gushin here and Dr. Sardi here. These two gentlemen, we have some experience with complex treatment. They are pioneers or some of the most prolific folks in the HIPEC operation, which is heated intraperitoneal chemotherapy and cytoreduction. So these are for patients with, among other things, carcinomatosis from certain kinds of cancers. And so that's obviously already a high risk situation, and also a high risk treatment. So we have some long experience on our team in terms of talking to patients about difficult treatment choices. Dr. Campbell here is a former professor at Johns Hopkins Hospital and also a pancreatic and hepatobiliary surgeon with long experience with these kinds of issues. And he and I form the main hepatobiliary part of the team. where we're often talking to patients about cancers like cholangiocarcinoma, pancreatic cancer, and doing surgeries like liver resections and Whipple's. So again, cancers that are hard to treat and entail some pretty high risk types of procedures, which hopefully we do well, but even more importantly, hopefully we help our patients make the right decision to pursue these kinds of treatments. So just to kind of come back to it, what do we mean? What I'm going to talk about a little bit is what do we mean by high risk cancers? What kinds of treatments are considered high risk? What goes into a person's decision to undergo high risk treatments? And what's the best way to approach that decision making process? I think as providers, sometimes we don't kind of focus on these questions, right? And help walk our patients through this process. So since I'm talking to you at the Cholangiocarcinoma Foundation, it's a good example of a high-risk cancer. Unfortunately, the data is such that compared to some other cancers, there's a relatively low survival rate. Even when localized, and when we're talking about localized, those are the patients that we're really talking about. For example, for a surgeon like me, that we feel we can get it out with a straightforward operation. Even in those cases, less than a quarter of those patients are alive at 5 years, which is unfortunate. And that's that's even worse for the patients who have extrahepatic bile duct cancers, where we're talking about the common bile duct or the bile duct down in the head of the pancreas. So, this is what I mean by a relatively low survival rate. So no matter what you're offering a patient, their likelihood of survival to 5 years is not high, but that's got to figure in to what goals they have for their own treatment. So again, I mentioned here the pancreatic cancer, hepatocellular carcinoma, and then duodenal and small bowel cancers. These are some of the things that we as upper GI / surgeons deal with, and we consider these to be relatively high-risk cancers. So unfortunately, with some of these high-risk cancers, the surgery for these cancers is also to be considered high risk. So for example, this study looked at liver resections for intrahepatic cholangiocarcinoma, and you can see here that depending on the extent of the liver resection, the mortality rate is not insignificant, and this is just part of some of the data. But an 11.4% mortality rate for an extended hepatectomy. For a straightforward major hepatectomy, it's about 7.4%. And for minor hepatectomies, it's 3.1%. So to think that for a mortality rate that's as high as 7.4% is significant. I mean, to put it in perspective, when we do Whipple operations for patients with pancreatic cancer or for cholangiocarcinoma in the distal bile duct, we expect, sort of as a quality control issue, that the mortality rate should be less than 2% or 2% or less. So for something to be, almost 4 times as high for a complex surgery is a pretty high mortality rate. And, to tell somebody that 1 in 12 or 13 patients who we operate on is going to die from an operation, that's a pretty high number. And of course, we are talking to folks who tend to be older and have other risk factors for complications. And so this just reflects the mortality, but the risk factors, the risk of complications is also very high. So in our discussions, we have to kind of help our patients, I think, factor these things into how they make a decision to move forward with an operation. It's generally true that we we as surgeons do a bad job at this. And in this study, for example, this was actually a study on interactions between surgeons and patients discussing pancreatic cancer. Only 20% of the surgeons addressed the long-term oncologic outcomes of the operations at the preoperative consultation. What that means is only 20% of the time did the surgeon actually talk about what benefit could be expected, i.e., how long would I live? How long would I live without a disease recurrence? How long on average do people live after this operation? What is life like after that? Only about 30% of the surgeons even reported that they felt like their patients understood the likelihood that the disease would come back. And only 30% of the surgeons reported their patients understood the fact that they could have postoperative complications. And it turns out that many of these surgeons, at least in this study, didn't necessarily believe themselves that it was helpful for patients to understand whether or not there was a likelihood of recurrence. Only 40% of the patients, so less than half the surgeons, thought that that was important for patients to understand. Now, granted, this was in a small group of patients and a small group of surgeons, but still, it's a remarkably telling piece of data to suggest that not only do we not do a good job at helping people understand what surgery is going to entail and what it means, but what benefit it's going to provide. And that's something that I think we do have an obligation to address. We are working on fixing these things. I mean, there are some various frameworks for helping patients understand their choice. And this is just an illustration of one of those frameworks called the best case, worst case framework. So what this illustrates is essentially like, okay, Mr. Jones, you have surgery. In the best case scenario, it's going to be a long surgery. You'll have an ICU stay. You may be, several days in the hospital. You may have to be in a rehab facility for some time. And that's what we consider the best case outcome for the surgery. But more likely you may be in, you'll have an ICU stay. You'll probably be in for a couple of weeks, and then you may have some issues with organ failure and require, say, for example, dialysis, and then the risk of death remains high for 90 days. And in the worst case scenario, there are complications due to surgery, and you could pass away without ever being able to say goodbye to your family. So for one of the treatment options, the framework suggests that you talk about what's the best case, what's the most likely case, what most patients experience, and then the worst case. And then you talk about the same kinds of things for not doing surgery or other options. For example, in this framework, it says supportive care. You're potentially talking about hospice as part of this, but time that you would in the best case, you'd have time to say, spend time with your family, get pain controlled, and pass away peacefully at home. Although more likely, with time, pain medicines kind of take over and you'll pass away in a facility. But the worst case scenario is, for some patients who are further along in the process, that they unfortunately get admitted and pass in the hospital before everybody has time to kind of absorb that process. So these kinds of things are choices that people should be, I think, making for themselves, or in addition with consultation with their family members as to what they want. And it then falls on us to help guide them through these conversations. So I'm going to pause here and talk about a patient. Actually, I saw her today, and she had surgery for a very aggressive left-sided cholangiocarcinoma, and we actually had to resect the left lobe of the liver as well as the extrahepatic bile duct and do a hepatocogegenostomy, which just means that you have to connect the bile duct for the right side of the liver. She had a very complicated course. She had a lot of comorbidities going in to surgery, and she had a very complicated course, including a leak from that biliary connection. We did manage it over time, but for several months she was quite miserable, to be absolutely honest. And she got through that, and she spent the next year or so kind of struggling with her overall health in the sense of energy levels and appetite and having weakness, not getting acutely sick, but just sort of really struggling. And then she started having a better time. But, as I talked with her over the course of that year, there were times when she kind of said that, maybe I wouldn't have chosen to go through this. And that's going to be one of the measures, actually, that increasingly we as surgeons or as people who work in this area in terms of research are going to look at that measure of regret, right? That how many patients regret having gone through some treatment or some surgery or some, once they've had to experience the sort of the hit to their quality of life. Now, thankfully, this lady did well enough for another year with pretty good quality of life, but that now has had recurrence in the right lobe of the liver, so metastatic recurrence in her liver. Now, for cholangiocarcinoma, she's actually done very well, and she's very cheerful now. She's actually been on durvalumab for 6 months. She has gotten sick a couple of times on that, but she's been tolerating it well, and she's stabilized her disease. So she's happy enough, but anytime we have a conversation, it's certainly true that she no longer expresses regret, but it's always a conversation that goes around how much she's been through over the past a little over 2 years now. And so for her, she's happy enough, but I would venture to guess that for some people, going through all that may not be what they had wanted to do. Thankfully, she's been able to spend time with family and take trips and do other things. So it's been worthwhile to her, but you can easily see how her course might have landed differently with a different person. So that conversation that I had with her at the start of our knowing each other, certainly we talked about getting neoadjuvant treatment prior to doing surgery. There were a variety of reasons that she really did not want to undergo chemotherapy. She actually, part of her delay in starting any kind of systemic treatment was she never really liked the idea of going on to chemotherapy. So either way, we talked about all the options, but one always wonders, did I really present everything in the proper framework for her to make a decision? And so, certainly I could have talked to her about the best case scenario, the most likely scenario, and the worst case scenario. I'd suggest that her overall course placed her for surgery somewhere between the most likely and worst case. She didn't pass away, was never, ICU ill, but she struggled a lot. So it wasn't what probably most people experience, but it was bad. And had she gone another route, it is true that probably she would have passed away earlier of cholangiocarcinoma, but had her goals been different, she would have been potentially satisfied with that. So that story to me, and seeing her today actually was really kind of interesting. The timing that I'm giving this presentation today was to kind of help me understand sort of how we talk to patients. You know, and so there are some new treatments for you know, intrahepatic cholangiocarcinoma that's not necessarily initially resectable. One of those is a hepatic arterial infusion pump. And this is just some data from Memorial Sloan Kettering. We're doing this here now too with some patients. But you can see here that, again, the survival for patients who are getting pumps at 2 years is about 54%. So you could almost say that 2 years is the median survival. Well, that's probably about the same, and some data suggests that it's about the same for patients who can undergo resection. So in this study, for example, patients with multifocal cholangiocarcinoma, you know, the results for resection and hepatic arterial infusion pump up to a certain point are pretty similar. The curves here separate out a little bit, but for the most part, at least early on, these two modalities actually perform pretty similarly. And so, you know, as more options come into play, we can think about avoiding some of the mortality risk and morbidity risk of surgery in favor of some of these other kinds of treatments that may allow us to temporize and keep people going until we can perform surgery. So it turns out the combination may be a better fit for some patients, and it allows us to help understand their goals. Hepatocellular carcinoma as well, we have many options now with immunotherapies. So for some patients, instead of pursuing very aggressive, you know, extended hepatectomies or even straight hepatectomies for patients with, you know, potentially resectable disease, if they have far gone cirrhosis or are at high risk in other ways, there are multiple new therapies that have really improved survival and need to be part of a surgeon's conversation with patients about how to make these decisions. So, you know, I know that this is kind of short, but what I'm hoping is that this has prompted some questions in among the viewers that we can make this more interactive and discuss in more depth. So, Lourdes, I don't know if you have had any questions come up on the call.
I do have one. Someone is asking, is it mainly possible for surgery to have it if it hasn't metastasized to other organs? So is that when surgery is it's only a viable option if it has not metastasized?
Yeah, great. So, so the benefits of surgery for cholangiocarcinoma really are mainly for patients who have limited disease. So it can't have spread to other organs per se. Now that also has to come with a caveat that in any particular patient's case, we do think about, well, how aggressive does this cancer seem to be, even if it has, for example, potentially spread to other organs. What do I mean by that? So let's say somebody has a tumor in the left side of their liver and there's a spot in the lung, a small spot in the lung. And we think that that spot is spread of disease from the liver. So how would we potentially approach that is to think about starting with chemotherapy. And then if we see disease stability, right? What I mean by that is the tumor in the left side of the liver doesn't grow, the tumor in the lung doesn't grow, and we're on chemo or immunotherapy, and everything's staying the same. After some time of that kind of treatment and some time of stability, it really, our teams should be asking the question at this point, is some form of local therapy reasonable to do? And then, so then you have to start talking with your patient about what they're willing to put themselves through. For example, if we could radiate the lung lesion or ablate the lung lesion in some way, or even sometimes laparoscopically resect the lung lesion and see that the liver has remained stable, then certainly we could offer, on a case-by-case basis, some patients to have surgery despite the fact that it has spread to another organ. From a statistical point of view, there's no study that's going to prove that we should do surgery for every patient who has metastatic disease. That's absolutely not the case. Most patients with cholangiocarcinoma with metastatic disease will have an aggressive course. So we know that surgery doesn't necessarily benefit, and we certainly wouldn't start with surgery. But we've even done some more aggressive things. One of my partners and I did do a Whipple for cholangiocarcinoma in the distal bile duct, and eventually did a cytoreductive surgery and HIPEC for that patient when they had spread in the peritoneal cavity. And she's still doing well today, and that was 3 years ago. So, on an individual basis, we always keep the door open, but as a certainly not as a first step. So if someone has metastatic disease, we really shouldn't be offering surgery up front. But depending if that disease is very limited and very stable on other treatments, then it can be considered. Does that answer the question?
I think so, yes. Perfect. There's a few questions about transplant. If you can speak to transplant and also what the age, like the cutoff for the age for transplant would be at your institution, that would be helpful.
Sure. So we don't have a transplant program at our institution. Our Mercy Medical Center is an affiliate, a teaching affiliate for the University of Maryland, and there is a transplant program there. But we also have many sort of shared patients with the Hopkins transplant program. So depending on how patients are coming to us and where their preferences are in terms of where they want to go, some of those patients certainly do get referred to transplant programs. It turns out that there aren't actually hard and fast rules about liver transplants in terms of age cutoffs, but transplants for cholangiocarcinoma are somewhat rarely done, and they're done more in specific centers rather than in all liver transplant programs. And groups like the University of Michigan and USC probably have more experience with transplants for cholangiocarcinoma than, say, the University of Maryland does. Hopefully I'm not speaking out of turn, but I'm not a transplanter myself. The use of transplant for cholangiocarcinoma, there is an experience certainly out there, and it's published, and in highly selected patients, it may provide some benefit. The criteria are not as clear as for, say, hepatocellular carcinoma. Some of those patients are patients who have what's called a Klatskin's tumor, which kind of happens at the bifurcation of the bile ducts, and therefore it's very difficult to sometimes to resect it cleanly without kind of taking out the whole confluence, and that creates its own problems. So some of those patients are evaluated for transplant. Certainly patients with a very high disease burden in their liver, like for example, if they have multiple tumors on both sides of the liver, I think if those kinds of patients had a very stable course on chemotherapy, for example, or on immunotherapy, they might be considered, but usually it wouldn't be something that happens right off the bat, because the reasons for needing a transplant are usually that for some reason the tumors are inoperable.
Thank you. Someone's asking, what are the limitations for the placement of a hepatic artery infusion pump? I don't know if you have an answer for that.
The limitations for the placement of a hepatic arterial infusion pump. That's a great question. So I think it really comes down to one, since by its very nature, the hepatic arterial infusion pump is only treating the liver. So it couldn't be considered a good treatment for someone, say, with metastatic disease outside of the liver. So that said, certainly patients who have adequate liver function, so the liver function as it stands is an important part of how we would make a decision about placing a pump. And what I mean by that is if someone has had a lot of chemotherapy, sometimes a lot of platinum agents can result in some progressive changes in the liver. And, if we don't think that they're going to do well with a hepatic arterial infusion of chemotherapy, that would potentially be a problem, right? So people with significant liver dysfunction would not necessarily benefit from a hepatic arterial infusion pump. It's often used for patients with disease on both sides of their liver, or with disease that's unresectable because it's, for example, say, involving the retrohepatic vessels like the IVC or the hepatic veins in too extensive a way, maybe sitting right on the main portal vein confluence. Those are all valid uses. Patients with multiple spots, of course, we talked about that. One of the, not a limitation, but one of the important things to watch out for is collateral damage, in the sense that when you implant the hepatic arterial infusion pump, we implant it in an artery called the gastroduodenal artery in such a way that it will go into the what we call the proper hepatic artery. So the hepatic artery comes over and sends off the branch, which is the gastroduodenal artery, and that becomes the proper hepatic artery. So we really want flow only into the liver, but there can be small little branches that take blood flow from that area to, say, the duodenum or even the stomach. During surgery, it's kind of up to us to make sure that we ligate those branches, and we're trying to see that we really only have perfusion of the liver. On occasion, some of the what we call anatomic variants of the arteries that feed the liver can provide some challenges, but usually as long as you kind of get into one of the arteries with the catheter, it's a reasonable thing to try. So the limitations really kind of are around, what is the extent of the disease burden? When do we think that liver directed therapy with chemotherapy is going to be of benefit? Sometimes anatomic issues, but liver function overall is the other part of the limiting factors for HAI placement.
Do you have any suggestions about how patients or patient advocates can work with doctors in improving honest and open discussion about surgical risks?
Sure. Yeah. So I think one thing is to be very aware of the kinds of barriers to that honest and open discussion. I didn't feel it was going to be the greatest thing to include every study that people have been done, but there have been a number of studies that looked at different ways of optimizing that conversation. The part of the problem is that it has been difficult to validate the benefits of any particular framework or any particular way of trying to incorporate more shared decision making, they call it, in the surgical decision making process. So what I presented, the best case, worst case scenario, I think has a kind of instinctive appeal. It turns out that there are studies that looked at whether this, what kinds of things that this affected. And what it seems to do is it does seem to improve patients' satisfaction with their care and whatever outcome they may have. And that's probably just a function of being more informed and understanding. So I think that it's important for a lot of surgeons, and some of the studies have demonstrated this. A lot of the surgeons feel a tension between being optimistic for a patient and offering some hope of an effective treatment. That tension versus what we know about outcomes is difficult, right? I often find myself saying that, well, there's a statistic and then there's you, and it's very hard for us to just based on one statistic tell you what your future is. You could be one of the 20% that's survived 5 years, right? So I can't tell you if that's you or not at this point in life. We try to be honest. I think that's what most surgeons try to do, but I think what happens is some of the conversational elements get glossed over in the sense of talking about outcomes, life expectancy, disease-free survival, quality of life issues, and part of it is also that there is a perception, and this is also validated by some of the research when people have asked surgeons or observed surgeons, there's a perception that getting into these conversations may take too much time, and may confuse patients, may steer patients away from potentially life-saving procedures. And it turns out that when you use certain elements of best case, worst case, for example, or other frameworks where you're really trying to optimize shared decision making, that there's no difference in the number of patients who say, okay, let's go forward with surgery. There doesn't appear to be a difference in their overall survival or outcomes. It's again in that patient satisfaction. And one thing that does go down is that that regret index, it turns out, at least in a few of the studies, that patients feel okay with their decision and don't regret their decision to move forward. So I think I think everybody's going to come to this a little differently as a surgeon, and hopefully as surgeons we can come at it a little differently on an individual basis with our patients. But I think there are at least three important elements. You should discuss what benefit we expect the surgery to provide. Obviously, we need to discuss risks of complications and mortality and potential bad outcomes in terms of quality of life. And then finally, probably the first step is to try and help our patients understand for themselves, and sometimes they don't know themselves, what their own goals are, what they want out of treatment. Some patients will tell you that, I just want to see my grandchild born next year, right? Or some patients will tell you, my grandson's graduating from high school in 2 years. Keep me going until then, right? They may have some milestone ahead of them that they wish to be around for. Others will be very, very clear about that they want everything done and they want to try and live as long as they can, and they're willing to, fight for that, and they want to be aggressive, and they, see no reason to hold back, so to speak. And that's a personal decision. That may be somebody who has a lot of things to live for, or has a lot of interest in life, or or just that's the way they've been raised, and they're sort of culturally that's where they are. um so there are a variety of things that go into why patients might prefer one framework over another, right, in terms of how we approach the decision. The person who wants to be maximally aggressive, um probably it's on us to be as informative as possible about complication rates and quality of life issues with that patient, not to try to dissuade them, but so that they go in with their eyes open. Other folks, the overall oncologic outcomes sort of discussion is more important, right? So if you think about someone who hopes to just extend their life for a certain amount of time, then talking about the average lifespan after these 2 or 3 treatments, surgery and chemo, will be X, Y, or Z. And you can reasonably expect to get there, or maybe it's unreasonable to expect to get there. And that may figure into their decision making.
Perfect, thank you. We have a question on what maybe you think is the value in exploratory laparoscopy when tumor and or mets do not show well on CT scan.
Yeah, so that has been a source of some variation among surgeons and among institutions. I know that at some institutions for a while, for example, for pancreatic cancer, all the patients underwent a diagnostic laparoscopy as a separate procedure prior to going to the operating room. That's been of more interest lately because the Mayo Clinic has recently published actually a nice study on the use of HIPEC in selected patients with pancreatic cancer and carcinomatosis. I think certainly anytime you have sort of high risk indicators that somebody may have metastatic disease that you're not picking up on, and typically in that regard, we're talking about the overall clinical picture. Are we seeing someone with a lot of weight loss and pain? Maybe they have ascites. Maybe they have a very high marker level. The CA19-9 is very high, or the CEA level is very high. Their weight loss has been very dramatic. Those kinds of markers and clinical picture tends to raise a certain degree of suspicion among us as a team. And so in that setting, I think a diagnostic laparoscopy is very useful. I don't always do a diagnostic laparoscopy for patients with intrahepatic cholangiocarcinoma, for example, or cholangiocarcinoma, for example, primarily because I'm more worried that what I won't see, I certainly can see extrahepatic disease and peritoneal disease, but what I'm more worried that I'm not picking up on their preoperative imaging is occult disease elsewhere in the liver. So in those patients, really, I think a good evaluation of the liver is important prior to performing the resection, but usually we just go straight to resection for those. And I do believe that imaging has gotten better even in the course of my career, such that we're not as often surprised by metastatic disease in the intraperitoneal cavity. I think we can still be sometimes surprised by metastatic disease in the liver, generally speaking, and sometimes that's apparent by laparoscopy, and sometimes it's not. So There are still some institutions which perform diagnostic laparoscopy as a routine prior to certain kinds of treatments. Certainly, we perform it prior to anybody undergoing a HIPEC surgery. We will sometimes perform it for patients undergoing surgery or potentially undergoing surgery or treatment for gastric cancer, and sometimes on a selective basis for pancreas cancer and cholangiocarcinoma, depending on what the clinical picture is. So I don't think it's mandatory necessarily. It can be useful, but it can also miss. So, sometimes you just have to go forward with an operation.
Okay. How much liver can be resected without compromising function? Does the remaining liver regenerate at all?
Good question. So, in a person with a healthy liver, and by that I mean somebody who really hasn't gotten a lot of chemotherapy, doesn't have cirrhosis, doesn't have a lot of steatohepatitis, which is more common these days due to general obesity. 25% of the liver remaining behind can be enough for adequate liver function. It's a little bit of a misnomer or myth that the liver regenerates. So it's not like a salamander's tail. So if I took out the right side of the liver, a new right side doesn't necessarily grow. What happens is what you have left will grow bigger. Sometimes in a very robust way, so it almost looks like a lot of the liver is back. So that is in the case of a healthy liver. So there are, unfortunately, for our patients needing liver resections, there are a variety of conditions that hinder that kind of what we call hypertrophy in response to resection. One of the main reasons people don't hypertrophy as well for things like colon cancer and sometimes for cholangiocarcinoma and hepatocellular carcinoma is prior chemotherapy. And not so much for hepatocellular carcinoma, but sometimes patients, especially those getting any kind of platinum medications, they get certain kinds of changes in the liver that impedes the hypertrophy of the liver remnant. So in those patients, we try to keep it at about 40%. So if you think about it, that's kind of the difference between a right hepatectomy and a left hepatectomy. In patients who've had chemo, as long as their liver function looks good otherwise and they haven't had too much chemo, we would consider a right hepatectomy. The other folks, of course, who have problems with this liver regeneration is people with cirrhosis. That part's been a little, how big a future liver remnant people with cirrhosis need is a little more fraught, because while everybody may be a child's A cirrhotic who could potentially undergo surgery, we try not to do that for people with child's B or C cirrhosis. But child's A simply means that you don't have a lot of biochemical issues, but you may have certainly significant portal vein hypertension. Portal hypertension can be a big problem despite having a child's A cirrhosis designation. But anyway, so for those folks, we try not to be overly aggressive in terms of taking out a lot of liver. So generally speaking, there are different ways of kind of assessing how functional the future liver remnant is, and those are specialized studies, sometimes not available at all places. But again, we don't want to really go beyond 40%, or less than 40% for our future liver remnant in those patients.
Okay. I know you mentioned CA19-9 and other blood tests that are done and scans. Do you ever look at other tests like the ctDNA blood testing in relation to whether or not a person maybe should have surgery?
Yeah, that's a great question, because we are coming into that era, I think, where we can do a lot of tests that can tell us about circulating tumor DNA, which is what ctDNA is, and there are a number of companies actually offering these sort of tests for circulating tumor DNA in the bloodstream that have been validated as predictors of overall outcome. What I think that we're all waiting for is sort of more real world data in terms of using that as a predictor of outcomes after surgery. So if we could kind of standardize a certain test and understand that, doing surgery after, say, a high Signatera or whatever the company it was. But there are a lot of competing companies. And right now we're still, I think, in a phase where it's not clear what impact these kinds of studies should have. As it is, our medical oncologists are kind of struggling with, well, some patients with these kinds of ctDNA tests, they may show that they are potentially having an onset of a recurrence, but but unfortunately that may occur before we have any visible evidence of recurrence on imaging. So this kind of sometimes puts our oncologists colleagues in a dilemma. Like, do they start treating a number? And the same thing can be said about somebody's CA19-9. It can start to go up, and it can go up without us actually seeing anything happening on scans. And so what do we do? Do we treat? So, given the sort of, it's a little bit ambiguous, right? I mean, we don't know that necessarily that a person with a high circulating tumor DNA measure won't benefit from surgery. Right? We don't have that evidence right now. So I don't think it's ready for prime time. There are academic groups looking at all of these kinds of things, looking at various various things that can be detected either in the bloodstream or in other modalities, but we're still awaiting something that kind of we can really sink our teeth into. We use CA19-9 for pancreas and certainly for cholangiocarcinoma. If it's really high, we worry, but we can never take it at its own face value as an indicator that we should or shouldn't do an operation. So we're not there with any of those types of markers yet.
Is seeding a potential issue or concern with exploratory laparoscopy?
It is for certain kinds of tumors, and one of the things that we do observe, for example, if we can just sort of considering gallbladder cancer as almost a variant of cholangiocarcinoma. It is of course part of the biliary tree. In that setting, when patients have cancers of the gallbladder, we do see seeding of the port sites, and that's why when, for example, if we go back in to do a little bit more of a radical liver resection and portal node dissection after somebody's been found to have gallbladder cancer, we excise those port sites. So we know it can occur. I worry less about seeding with intrahepatic cholangiocarcinoma, of course, because it's kind of contained in the liver. So if I'm going forward for surgery and I want to put a camera in to make sure everything looks okay, I'm less worried because that should be relatively contained, especially if we're not violating it. Obviously, when we do surgery for these things, we try not to, spill anything or expose anything inside the abdominal cavity to whatever degree we can.
I know that we've had a lot of patients ask about their stents and whether or not if they have a stent placed, they are no longer a candidate for surgery. I was wondering if you could share a little bit of insight on that.
Sure. So as that question indicates, many patients with cholangiocarcinoma and pancreatic cancer, for example, will present with some kind of situation reflecting obstruction of the biliary system. And that's why those stents are placed. Stents can be placed in a number of ways. One way of placing a stent in somebody who is blocked is to do what's called a percutaneous biliary drain. And some patients have these where an interventional radiologist will put a needle into the liver and thread a wire, and over the wire insert a catheter. And sometimes they're able to get that catheter beyond the blockage and into the duodenum. And so that's one kind of flavor of stent. And then more commonly, maybe these days, is patients with this kind of problem are first referred to an advanced gastroenterologist to place a stent endoscopically, and that may be a relatively short plastic stent if the obstruction is sort of in the extrahepatic bile duct. Sometimes it's going to be a covered metal stent. And the distinction between those two is somewhat important when considering surgery, but having a stent is not by itself a contraindication to doing an operation. It's just a matter of, sometimes it's a matter of timing. So if you have had a person undergo an endoscopic stent placement, for example, and they may have a bout of pancreatitis, you're going to want to let that pancreatitis resolve prior to doing an operation. Some patients with metal stents can have quite a bit of inflammation that occurs immediately afterwards, but that also tends to be ongoing. So we're sort of trained to expect a lot of inflammation and fibrosis then, but it's not a contraindication to having an operation necessarily, depending on the situation.
Thank you. That's really helpful. I know that we are at an hour mark, and I want to respect your time, and I appreciate you answering these questions and giving us your perspective and the surgical team's perspective on how you evaluate and provide difficult information to patients. So I really appreciate that. We do have a few other questions that have come through, but I might just try to send them to you offline, and if you have some responses to those, that would be great.
It would be my pleasure. Thanks very much for letting me participate in your program.
Thank you. Thank you, everyone, for being here today.